Next, we're going to speak with Dr. Doug Fridsma, the Chief Scientist at the Office of the National Coordinator for Health IT, and the person, as much as anyone, responsible for many of the innovations in health IT we've been discussing during this course.
Doug, I imagine you're probably the busiest person of all the people I'm interviewing for this course, so I really appreciate your finding the time, particularly when you're on vacation, to be with me and the students this morning. You've sort of been, I think, the futurist, the thought leader when it came to health IT and the future of health IT at the Office of the National Coordinator. I guess we're now 6 years into high tech. Adoption has certainly gone up dramatically. How do you feel about where we are at this point? Are you satisfied?
So Mark, let me just first say I'm delighted to be here and have an opportunity to have this conversation. I say hello to you and to your students, and I hope that we have a good opportunity today to sort of talk through some of the challenges that we've had at the Office of the National Coordinator. So with respect to kind of where we are now and where I think we need to go, this has been, meaningful use was established through Congress and had very tight time frames. And we really took the Meaningful Use program and divided that into 3 different stages. Roughly speaking, Meaningful Use Stage 1 was about adoption. There's certainly, you have to first get people to use electronic health records and put that information into electronic formats and before you can actually go to the next step. Meaningful Use 2 is really about exchange. And it's about, once it's in an electronic format, is there a way that we can begin sharing and leveraging that information so that as patients have their medical record or their care delivered in lots of different settings, it's possible that that medical record and that information can follow them as they move through the healthcare system. And then when we think about Meaningful Use Stage 3, we really are talking about making that information useful, making it useful for doing quality assessment, being able to pool and aggregate and learn about how it is that we're taking care of patients. So if you think about meaningful use as being adoption, exchange, and then using that information to improve quality, that really defines the kinds of things that we're trying to accomplish. I think it also fits into what our definition of interoperability has been, and as you know, that is the holy grail, if you will, or the thing that we've been striving to achieve. And interoperability is really about exchanging information and then using the information that's been exchanged. And so our meaningful use, our approach to meaningful use really is driving towards this notion of an interoperable electronic healthcare record system that will help enable patients by getting adoption first, then going and making sure that we can exchange that information, and then making sure that we can use that to improve quality. So we're early in the process. We've really only completed the first phase, if you will, of meaningful use, which is around adoption. And as you've said, we've really made some good progress there. We've gone from about 17% adoption of electronic health records among sort of general practice, upwards of 65% of adoption at this point. And certainly among all of our academic medical centers and things, we're really approaching 95% adoption of electronic health records. And so I think we can say that Meaningful Use Stage 1 has achieved many of the goals that we had, which was getting people to begin transferring or transitioning from paper-based records to electronic ones. Meaningful Use Stage 2 is harder. We've raised the bar. Interoperability and exchange of information is a more complex problem that involves not only the technology, making sure that we've got systems that can talk with one another, but having the right business processes and the right business drivers that will make that something that people will want to do naturally. And so I think when we think about Meaningful Use Stage 2, it's harder. I think we're early in the process, and the pace is very, very fast. And so I think we need to see where we are with Meaningful Use Stage 2 and see what sort of progress that we've made. And I think regardless of kind of where we are, this is a course that is inevitable. I think as we get the right technology in place and the right business drivers, it's going to become important that that medical record begins to be distributed and used to help support patient care and care delivery.
Well, traditionally, the sharing of health information has involved something called a health information exchange, which the students won't yet be familiar with when they see this interview. But they'll learn that one of the key problems has been achieving a sustainable business model for health information exchange. ONC has invested a lot of money in helping the states launch health information exchanges. At the same time, the technologies that people might use to exchange information are changing dramatically. So as you look ahead, what do you see happening in that area?
Sure. Well, I think when we think about exchange, the health information exchanges really are going to be a central player in making that happen. I think one thing, though, to remember is that the United States is a big place. There's lots and lots of different organizations and participants in the healthcare ecosystem, if you will. And so it's really not going to be, I believe, a one-size-fits-all solution. You know, I liken it to the way in which we currently communicate and exchange information, for example, with our family. I'll use email, I'll use the telephone, I'll use text messages. There's lots of different mechanisms by which I might communicate with my family. And I think when we think about the complexity of the healthcare system, we have to understand that it's not a one-size-fits-all solution. So to that end, I think part of the early work that we did was to say, listen, if I'm a doctor and I just want to send it down to my local pharmacy, it seems a little hard to say, well, we have to send it to some big database centrally and then it has to come back to that pharmacy and things like that. And so sometimes what we need are simple ways of exchanging information, like, you know, replacing the fax machine, if you will. And I think part of what we've tried to do is with the Direct project, try to create mechanisms that I can send things directly to someone who needs to get them, whether it's for a consultation or electronic prescription or the like. But I think that is necessary but not sufficient for the kinds of things that we'd like to do. Remember, our goal is to eventually get to the place where we can exchange and aggregate and analyze and learn from the information that's there. And I think health information exchanges are going to be tremendously valuable, particularly as we think about accountable care organizations, and we think about care that's delivered across the continuum. That includes not only your primary care doctor, but it includes other subspecialists, and perhaps there are home health services and other things like that that need to be involved. And health information exchanges, I think, can really help us there. What we found, though, is that those health information exchanges that rely simply on paying a toll to send the information from one place to another, if that's their business model, they struggle. That is a hard business model to sustain because there's always simpler and easier ways to get around that. So for example, although the telephone company may want you to have a landline and keep that working in your house, you could circumvent that with your cellular phone. Or you could circumvent that all entirely by using Skype or other ways of doing things. So I think business models that are predicated on just paying a toll within the HIEs are somewhat problematic, and they will struggle, I think, to try to make sure that they can provide value. Those that we've seen that have been successful, however, are those that have been able to move up what I would call move up the value chain. So rather than just providing a toll road for information to flow on, they provide additional services. So they are able to find information because they've got aggregation features that otherwise would be difficult to get. Vaccination registries for children that are going off to camp or starting school. That's oftentimes a hard thing to sort of find information on. And HIEs that provide that as a service, I think, will find themselves providing additional value to the folks that use them. I also think with the ACOs, it's going to be very, very important, the accountable care organizations. It's going to be very important that people understand where the high-cost patients are being taken care of and if there are ways that they can reduce those costs. And that's going to take the aggregation of lots of different pieces of information. And so I think HIEs that can kind of move up from being just a toll road in which information flows to something that provides a lot of additional value with analytics and connecting the dots and making sure that doctors have a full picture of the patients that they take care of. I think those are the ones that are going to succeed as we go forward.
Well, those are great comments. I hope the students keep those in mind as we move into the topic of health information exchange and as we look at the Indiana Health Information Exchange as maybe the premier example of value-added services. Well, let's get back to this topic of interoperability. I remember when high-tech was first announced, I was very surprised to hear pushback about doing it then from longtime HIT advocates who said that we'd be deploying a whole bunch of non-interoperable systems that might be frozen in place forever, making interoperability impossible to achieve. Contrast that with the recent JSON report, which the students don't actually know about yet, but a report by a group of distinguished scientists that points the way toward what they call a robust interoperability framework for healthcare in the United States. How do you see this unfolding? How are we going to turn these hundreds of different brands of electronic health and personal health and other record systems into something that is robust, as the JSON report envisions?
Yes, and this has been one of the fundamental issues that we've been working on, I think, within the Office of the National Coordinator. So we've had a number of years, probably 10 or 12 years, in which there are organizations that have worked on developing standards and specifications that would support interoperability. We have organizations like the Integrating the Health Enterprise, or IHE, which does a tremendous amount of work on trying to develop all of the pieces that would allow interoperability to occur, both within an enterprise and across different enterprises. HL7, as a standards organization, has also worked on both creating interoperability within the enterprise as well as between different organizations. But we've done that oftentimes by developing the standards first and then hoping, based on our best guesses, that this will serve the needs of the folks that are out there. Some have been tremendously successful, and others, I think, have languished or have had struggles. And I think when we started with Office of the National Coordinator and down this path towards interoperability, we were faced with a conundrum. Do we wait until the systems are perfect and that we've been able to demonstrate interoperability? Or is the best way to achieve interoperable solutions is to get things out there and to try to make sure that people have things that are electronic and then begin struggling about creating that interoperability? And I think what we decided was that it's difficult to predict or develop interoperable solutions in a committee. You really need to get it out there and you need to make it work. And that's how you're going to be able to sort of struggle through the complexity, because interoperability is the devil is in the details. It's really a good concept, but you have to be able to define it. Again, if you think about the definition, the IEEE definition of interoperability, it says it's about exchange and it's about use. And so the use of the information means that interoperability can't be defined in the abstract. It has to be defined in actually doing something. And so I think we decided early on that the way to get to interoperability was to get things out there and to try to get them working and then struggle, if you will, to try to make sure that we get those pieces right. Not to try to make the whole system kind of top-down perfect, but to try to figure out ways that we could let real uses bubble up and provide the mechanisms for interoperability. So to that end, one of the things that we've done is we've also tried to mitigate our risk. And we've modeled a lot of what we've done off of the way in which the internet is organized. So when they created the basic functionality to support the internet, what they didn't do was create some big system that had perfect ways of representing information that these physicists wanted to use and created kind of the system that everybody would have to interact with, one giant database, if you will. What they did instead is they said, let's create a standard for how we format information. Let's create a way that we define specific keywords so that the computer and the browsers can understand that. Let's provide specific formats for how we move information around and how we secure that information. And so our approach has been to break the puzzle up into really 5 fundamental building blocks that support interoperability and that are modeled on the way in which the internet has been established. So we try to standardize 5 things. We standardize meaning through vocabularies and terminologies. We standardize formats through HL7 and other kinds of structures that allow us to move that information around. We standardize transport using specific ways of moving that information, many of them based on secure email or based on web services. And then we standardize security so that I can encrypt it on my end and you can decrypt it on your end. Now, if you take those 4 things, meaning, structure, transport, and security, and you package them together, you get essentially what would be the fundamental pieces of an application programming interface, or an API. And in the JSON report, which hopefully people will have an opportunity to read about, they really talk about using APIs as the way of creating this framework for how that information can flow. And many of their APIs are also organized according to the layers of that particular stack. So a stack that helps us with meaning and vocabulary, another one that helps us with how we access data in structured ways, another that helps us with authentication and with security. And so, in fact, many of the things that we've been working on within ONC, creating those building blocks, are also mirrored in the JSON report that's coming out. So it's not a perfect system. In fact, we still have a lot of work that we need to do, and we have to move forward. But we don't think we can get to interoperability from a top-down approach. We really need to kind of, not even a bottom-up, we have to do it from the middle out. And by creating these fundamental building blocks, many of them that look like those that are used in the internet, by taking an incremental approach where we focus on those things that have high value, again, related to the conversation around HIEs, and then incrementally over time build out the various APIs and the various standards that we need, we think that we can achieve interoperability at least around some things, and that we can over time make it more and more interoperable as we go forward. Within the internet, we are at HTML version 5. And so we've had 5 iterations in the standards that we use to describe that. And I would say that within healthcare, we're really not even quite to HTML version 1. And I think we're still going to need some time to get some additional work done. And it's going to be students and people who are trained in informatics that are going to be able to help us get there.
As you look out over the next few years, what do you see happening from ONC and HIT in general?
Well, I think, as we come into Meaningful Use Stage 3, I think there's a tremendous number of people at CMS and at ONC and others that are really trying to define what the specification should be within that. There's a lot of conversations that are ongoing at this point. It's difficult to really know kind of where we're going to land with that. But I think what we want to do is we want to make sure that we've learned the right lessons from Meaningful Use Stage 1, that we are looking at Meaningful Use Stage 2 to see what's working there and what's not working there and trying to make refinements that we need to do. And then to look ahead to where it is that we want to go. One of my favorite phrases is that we, in addition to not letting perfect be the enemy of good, we don't want good to be the enemy of better. And what that means is that we sort of want to take this path of least regret. We want to go down a way that we can create that incremental approach to getting to where we want to go, and not get in the way of getting to a better place as we move forward. So as we look at Meaningful Use Stage 3, we really want to make sure that people who were early adopters of electronic health records that have supported the Meaningful Use Stage 1 and Meaningful Use Stage 2 programs continue to be successful in the things that they're working on. And then what we want to do is we want to say, are there other things that people are telling us are significant value-added propositions, if you will, that would allow us to get to a better place? And how can we make sure that as we create this incremental path, that we continue to move towards that better place that we'd like to be? You have to remember, too, that meaningful use is really composed of 2 different kinds of regulations. The first is around the electronic health record and the kinds of technical capabilities that electronic health record needs to have to support the doctor and to support information exchange and to support the other goals. And then the second part is having the doctor use that information and demonstrate that they're able to sort of provide increased quality, or that they're providing better access to that information as well. I think as we look at Meaningful Use Stage 3, we really have to think about adoption, exchange, and then what are the important uses that we'd like to see there. And I think one piece that's important also to consider is the work that we've done on making sure that patients have access to their information as well. And that's, I think, a fundamental need to make sure that we include the patient in this health ecosystem, Because otherwise, I mean, to me, it would be a tragedy if what we ended up with was a separate but equal system. One system for the healthcare system and one for patients and consumers and others that are interested in improving their health. I think when we think about accountable care organizations, when we think about how we take care of all these patients, we have to make sure that the patient is considered a first-order participant in their healthcare and their healthcare delivery.
Well, Doug, I want to thank you again for taking the time with us. I suggest the students may want to watch this interview again toward the end of the course, because you've sort of woven together many of the themes that we pursue throughout the whole course. So thank you so much for taking the time to be with us.
Thanks so much, Mark, and I wish you and the students well as they sort of help us get to a better place with health information technology.